Welcome to today's webinar on post-COVID condition. As we gathered here today, we acknowledge that we are on Treaty 2, 4, 5, 6, 8, and 10 territories in the homeland Métis. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. To begin, we have a quick poll. So the majority of individuals attending, there's actually quite a diverse range. We have about a quarter are nurses, a quarter are physicians, and we have about 20% that are patients as well, and then additional healthcare providers. Then we have a second poll. We want to about the knowledge so far in the group. All right, we have a range of knowledge in the group as well, with the impact of post-COVID condition having a mix of all levels. And then we have appropriate steps for diagnostic. We have a mix of low and moderate, and then CAN-PCC Guidelines is majority low. Thank you for completing those polls. So those who are attending, this is this accredited session. Following this webinar, you may receive a certificate and an evaluation form. The recordings will be available after the series. So please post questions in the anonymous Q&A function or with your names visible in the chat. During the Q&A, you can also raise your hand and unmute. These are the steps we have taken to mitigate potential sources of bias. Our speakers today include Dr. Rachana Bodani, an assistant professor of psychiatry at the University of Saskatchewan with a clinical practice in sleep, general psychiatry, and operational stress injury. Melissa Croskery is an occupational therapist at Continuum North who's been practicing for 24 years with expertise in general pediatrics, child and youth mental health, trauma-informed practice, and self-regulation. She has lived experience with long COVID, including brain fog, and is CAN-PCC co-chair of neurological and psychiatric topic. And these are their disclosures. And then on to the presenters. So learning outcomes.
Thank you. Melissa and I are going to go back and forth today, but I'll get started and I'll just kind of read to you the objectives that we have for today. We would like to be able to help ourselves and others identify the impact of the post-COVID-19 condition on mental health among patients and families. We hope to describe the appropriate steps for the diagnosis of mental health conditions and management as a part of the post-COVID condition, and we hope that then you will be able to integrate the guidelines as they relate to mental health and into a healthcare practice for those of you that are working in the field. Next slide. So no presentation about anything related to neuropsychiatric or mental health conditions is complete without a few statistics about what's kind of going on in the world right now. This is some data from Canada, which is nice because a lot of our data comes from the US, but the Stats Canada data from 2022 looked at 5 million surveyed, and they saw that 18% of individuals age 15 and up met the diagnostic criteria for mood, anxiety, substance use disorder, or something in the last 12 months, in the 12 months prior. And this is by no means to suggest that when you look at these numbers, that the increase you can see from 2012 to 22, this is by no means to suggest that it's the post-COVID condition that is responsible for this. But I think it's really important to highlight that we have a whole range of symptoms and conditions that are very difficult to specify. Like, we can't do a blood test for any mental health disorder. And so it's very non-specific. A lot of these symptoms that we're going to describe, they're multifactorial. It's not just one condition that can contribute. And so there can be quite a complex sort of presentation with etiology that spans across domains, whether it's medical, like viral, mental health, social, etc. So we already are in this world where we have a lot of symptoms present, and now we're looking at another added complexity. And the other thing I think I'd like to stress is this piece where it says that more than 1/3 reported unmet or partially met health or mental health care needs. And I think that's really important because we know that treatment and resources are lacking or at least under-resourced. And so now do we add to this even more complex presentation of symptoms, so the needs will grow and have grown, and yet our resources are still finite. And so hopefully this presentation will help us meet the needs of our patients and our family members, etc. And hopefully it kind of validates the experience that people are having. Next slide, please. So this is what we call the stress diathesis model. And I think it's really important because it will hopefully illustrate the relationship we have between different conditions and stressors and what the contribution of our own baseline factors is. So whenever we talk about anything like within the stress diathesis model, we're thinking about the P's. So we're thinking about a person's predisposition. Then we think about, so that's someone's baseline level of risk, right? So if we're talking about a mental health disorder, if we're talking about the post-COVID condition in general, we know that, or we're hoping to identify, we know that there are some risk factors already that put people at a higher or lower level of risk to develop the condition itself. So so this kind of explains why not all people who experience COVID are going to develop the same types of symptomatologies. And even within that whole post-COVID cluster, some people are more likely to experience some kinds of symptoms while others are more likely to experience others. So there's presumably the impact of whatever genetic predisposing factors that one already has, not only genetic, but also previous lived experience as a predisposition. And then we have the precipitant. And in this condition, we would say the precipitant would be the virus itself. So there's our stressor. And in most cases, once a precipitant decreases slowly, we would expect the symptoms to go down. And you should get back down to this nice red bar again in terms of symptom presentation. But sometimes there are factors that will keep symptoms present even if the initial stressor is gone. And those are our perpetuating factors. And that's where the condition becomes chronic. That's our chronicity. And so we know that once someone is infected with a virus, the virus eventually clears. But what we have learned is that symptoms can continue. So if we can kind of put it in this model, we can think about, like, what are we targeting? Are we targeting someone's predisposition when we treat a disorder? Are we suggesting that someone who already has a predisposition to the development of a mental health disorder would then have a higher risk then of that precipitant pushing them over? And if so, can we do anything to modify the other bars, even if we can't modify the precipitant itself? So I know that's a bit abstract in some ways, but hopefully it makes sense as we continue to talk about it. Next slide, please. So if we get to the meat of what we're looking at, so we know that mental health disorders are extremely common in the post-COVID condition. And one of the really large studies was a US study with over 25,000 participants. And what they saw was that people who are experiencing the post-COVID condition, which again is not just neuropsychiatric, but all the other features of it, they were then twice as likely to report depression and anxiety symptoms than other US adults. And it's very then complicated to try to say, okay, well, was the COVID a precipitant of a mental health condition, or is this a symptom or perpetuant of COVID itself? So that's where things get tricky as a clinician to try to identify. And that's where it can be a challenge to figure out, like, what am I treating? And that's where hopefully these guidelines are going to give us more and more information moving forward. Next slide, please. So if we look at the data from that comprehensive review in 2022, there are a whole bunch of symptoms that we can classify or characterize as neuropsychiatric. And you can see that there is quite a wide range, even within these. And some of the more common ones, like sleep disturbance, fatigue, cognitive impairment, anxiety, these, again, depression, these again, they're very kind of non-specific sounding. You can't experience one of these symptoms and be led clearly to one diagnosis necessarily. And so it can be very difficult because there are a number of confounding factors when a patient or presents this way, or when a person experiences these symptoms. As an individual, you might experience sleeplessness, but do you necessarily associate it with a particular condition? Maybe not. Maybe there's more than one thing going on. Maybe these are things that have already existed but become worse. But whatever the situation or the scenario might be, we know that there's actually quite a few different ways that the condition can present when it comes to just neuropsychiatric presentation alone. Next slide, please. From what we've seen, there are some identifiable risk factors, especially that large study. What they saw was that some of the risk factors for developing these chronic neuropsychiatric manifestations included the severity of the infection, the female sex, the presence of comorbidities, so other illnesses, a history of mental health disease, and elevation in the levels of inflammatory markers. So we know that, there's at least what we're identifying is some predisposing factors that will add to risk of developing the condition. But what the actual mechanisms are is still, we're still studying this. Like we can't draw that clear arrow from the condition to the symptom to explain exactly why everyone or those that experience the symptoms are experiencing them. And of course, we still have to think about the role of indirect effects. So there's direct effects on health and the physiologic part of this, but there's also the social pieces of this and other aspects that will affect quality of life, which could then also then contribute to some of those symptoms. Next slide, please. And so this schematic kind of puts that into perspective. So if we think about like what are the mechanisms that are causing those types of neuropsychiatric symptoms, we can think, okay, there are some theories around, could it be related to inflammation? We know that because of the evidence of increased markers in people who develop it. Is it related to ischemia or social changes, environmental changes? We know that there are risk factors that are just related to the individual themselves. And then we also know that there's going to be differences potentially between the different variants of the virus. Like, are the different variants going to lead to the manifestation of these types of symptoms, one more so than the other? So we know that in the acute phase, this is what we look at as the blue box, right? And then for prevention, it's related to, can we change any of those factors or not? And then once we're there, once we have symptoms, then we're actively, hopefully, looking for those manifestations. And then once we get past that 12-week threshold, now we're looking at the diagnosis of the condition. And we have to think about what is the prognosis going to look like? Is there going to be positive improvement or poor? And we can look back at the patient and the individual factors to try to help guide that. Next slide. I'm going to pass it over.
Yeah, thanks, Rachana. So we, including myself as part of the CAN-PCC collaborative, want to acknowledge that people with lived experience of PCC often experience challenges with acknowledgement of their condition, with getting diagnosed, with being believed with what they're, telling their healthcare providers, and that there's that worry about medical gaslighting, which is
the term that's often used for that. And so we want to really encourage that care must be taken to avoid confusing the symptoms of PCC with those of mental health conditions. Now, as Rachana mentioned, it can be hard to tell sometimes because some of the same symptoms you would experience with a mental health condition, you might also experience with PCC. And so we just really want to stress that the aim with our recommendation is to look at mental health disorders that occur concurrently with PCC. So you're diagnosed with PCC. We know you have PCC. We believe you have PCC. Do you also have mental health, a mental health disorder or mental health symptoms that we can also support and treat? Next slide. So one of the first things that we did is to release some good practice statements. And so good practice statements are when we know there's lots of evidence to back things up, and we don't want to take too much time to have to go through and look through a bunch of studies. And it's really a rigorous process in terms of developing the guidelines. So the first one that we developed, and it was actually in our group, was that healthcare professionals should inquire about limitations in daily activity and quality of life on an ongoing basis for people with diagnosed or suspected post-COVID-19 condition who experience symptoms. So this is an ungraded good practice statement. And just as remarks, inquiry should be accessible, appropriate, and culturally responsive. So next slide, please.
So I'm just going to spend a minute to talk about assessing quality of life. Quality of life by itself, like face value, can be a very general and broad term. And there has been quite a bit of effort in looking at, how do you define this? And there's different ways of looking at it. There's the approach of looking at specific different domains of life and then assigning like a numeric like a number to it, and then getting the sum of it to see how someone would score. There's the way of looking at it completely subjectively. Assuming that you have taken into account all those objective factors yourself, how satisfied are you with the quality of your life? And there are approaches that will combine all of those. So there are over 150 different screening tools out there that assess quality of life in one of those ways or a combination of those ways. And so it can be a bit tricky to really figure out, if you are trying to assess someone's quality of life, what the best way to do that is. And of course, we're going to take the individual's subjective experience to be, in my opinion, one of the most valuable and important pieces of this, because if they're not satisfied with the quality of their life, then no matter what the numbers or the scale show, it doesn't really matter. But in healthcare, we do often like to assign some kind of value and try to get some idea of what a baseline is, often just so we can measure change, right? So that we can see if anything we're doing is helping, and we can see if things are getting worse or better. I've listed a number of scales at the bottom there. There's so many that are available, and if you save the slides and you go looking for them, most of them are like public domain and free to access. The Flanagan's one is probably one of the most widely used assessments in the healthcare sector, and that looks at various different domains. The last one there, the HR HRQOL, that is actually one of the most succinct. So is the Soderjun's Global Quality of Life Scale. That one in particular is just like one question, so it's ultra succinct. So definitely lots of different ways to assess. Next slide.
So we wanted to take a minute just to explain what the implications are of a strong and a conditional recommendation. Lots of different terminology used when we're creating these guidelines. So when we're looking at our recommendations, we are looking at patients We're looking at healthcare professionals, and we're also looking at policymakers, right? So if it's a strong recommendation for patients, that's going to mean that people are going to want to follow it, and maybe a small proportion would not. Healthcare professionals will want to prescribe it. Adherence could be used as a quality criterion or performance indicator, and decision aids are not likely to be needed. And for policymakers, if it's a strong recommendation, policymakers will want to adopt it in most situations as a performance indicator. If it's a conditional recommendation, then for patients, most people will want to follow it, but many would not. Most people will want to discuss it with a health professional first. For healthcare professionals, most of them will want to prescribe it, recognizing that different choices will be appropriate for different patients. Decision aids may be useful to help people make a decision consistent with their values and preferences. And for policymakers, policymaking will require substantial debate, and policies are more likely to vary when it's a conditional recommendation. Performance indicators would measure adequate informing information and discussion. Yeah. Next slide. Okay, so I'm going to present one of our first recommendations through the guidelines in our group. So this one was screening for depression. And the recommendation is that the CAN-PCC Collaborative recommends the use of screening for depression over no screening for adults with post-COVID-19 condition. And this is a strong recommendation with moderate certainty in the evidence. Just to note, screening is intended to ensure that in addition to managing post-COVID-19 condition symptoms, depression can also be detected and treated. Next slide. So in regards to screening tools, when we were looking at evidence regarding screening for depression, we did note that there's some fairly strong recommendations against using standardized screening tools. And that's because there's just, there's the possibility that we're going to miss some important information, especially when, again, we have some of the parallel symptoms between PCC and depression potentially. We're going to need to go a little bit deeper. So the CAN-PCC Collaborative does recommend against using standardized screening tools and recommends instead using a structured interview. That being said, there are many screening tools out there, and Rachana is going to tell us about some of those.
Yeah, thanks. So, yes, there are many screening tools out there, and if you're a clinician, you've probably used them. And if you're a patient who's ever gone to a physician to talk about any kind of neuropsychiatric complaint, you may have completed some of these. What I'll stress about them is that they are probably most useful as a screening tool to decide who to further screen. Okay, so they're not diagnostic. They were never meant to be diagnostic for any individual or any patient for any assessment. But it might be that one thing that actually triggers a clinician's mind to say, okay, this person is scoring high on this particular tool. And you might then be guided or triggered into asking more questions about it. And as a patient, as an individual, these are readily available online. If you're ever Googling, what is depression? Am I depressed? You often will find these websites with the scoring, because these are all free public domain tools, most of them anyway. And you might fill it out, and it might say something like, oh, moderately depressed or something. And again, to understand that the tools were never meant to be diagnostic. They are helpful in reminding us to look for certain things. And so, and also to measure progress, actually. So at some point, if you have determined that someone is suffering from depression, then you can monitor their symptoms and their progress using these tools. So that's just a way to think of them. The one I've shown here is one of the most commonly used tools, from family physicians' offices to psychiatrists' offices to anywhere else, really, even other medical fields. And it's called the PHQ-9, and there are 9 questions, and it's self-report. So the person filling it out will have a read and decide whether or not they feel like they're experiencing those symptoms and how often. Next slide, please. And then when we look at how it's written in terms of how to interpret the score, we would look at just the range that each individual would fall into. And they do have treatment recommendations that come with this based on what would be a provisional diagnosis. So we would never treat based on a score ever. We would get a score, we would do a structured clinical interview, we would determine what the diagnosis is. We can use the score to help assess some idea of severity once you're past that initial screen, and then you can look at some of the recommendations. And this particular scale has a sensitivity of about 88%, so it will pick up quite a few people appropriately that have depression, in that the people who are screening positive on the scale are likely to actually have that. You're probably going to catch most of them, and it is specific for depression. So that's I think kind of good to know. Next slide, please.
Okay, so our next recommendation is similar, and it's around screening for anxiety. So the CAN-PCC Collaborative suggests the use of screening for anxiety over no screening for adults with post-COVID-19 condition. And this is a conditional recommendation based on very low certainty in the evidence. And again, the remarks are that screening is intended to ensure that in addition to managing post-COVID-19 condition symptoms, anxiety can also be detected and treated. Next slide.
And so, like, similar to screening for depression, there are also a number of validated screening tools used for anxiety. And it's the same idea in that we really aren't using these tools to be diagnostic. Again, it's to flag us, and also then to help us monitor. Next slide, please. So one of the most common screening tool for anxiety is the GAD-7 or the GAD-7. And very similarly, it's self-report. It involves, an individual sort of rating how frequently they would experience certain symptoms, and then adding that up and seeing how they score. Next slide, please. And again, there's this interpretation that we use. Now, one thing I'll sort of highlight that's a bit different between screening for anxiety and depression is that PHQ-9, that depression screen, really asks a lot of symptoms that very directly can relate to depression, which is why we say it is specific for depression. The GAD-7 is a little bit different, actually. That doesn't point to a diagnosis. Like depression is a clear diagnosis. GAD-7 doesn't actually point to a diagnosis. It just points to anxiety in general. And there can be so many different types of anxiety and different diagnoses related to anxiety. So again, that structured clinical interview is still necessary if you are suspecting that someone is struggling with this as a part of their post-COVID condition. Next slide, please. Now, I've thrown this in, and it's not that there's a recommendation for use of SSRIs, and Melissa will speak to that, but we use them. We know we use them. We're using them all the time in our world. And so I just wanted to throw this up there so that you can have this as a resource. And this is from the most recent iteration of the Canadian Mood and Anxiety Treatment Guidelines, which are well-respected guidelines internationally. And basically, the table is just highlighting which medications are most favorable or least favorable. And again, this is not specific to a post-COVID condition. This is just generally a diagnosis of depression and actually anxiety as well, but depression when it comes to this particular chart. Next slide, please.
Yeah, so in terms of recommendations that have been released so far, there is one recommendation that does speak to both SSRIs and SNRIs, but it was looking specifically at prevention of post-COVID. So for someone who has an acute COVID-19 infection, could they take SSRIs or SNRIs to prevent developing post-COVID condition? And so I'll just read the recommendation. The CAN-PCC collaborative suggests against the use of selective serotonin reuptake inhibitors and serotonin and norepinephrine reuptake inhibitors in people with acute COVID-19 infection to prevent post-COVID-19 condition. And this was a conditional recommendation based on very low certainty in the evidence. I think there's information in the chat about the certainty of evidence as well, if you're interested in more information about that. But as you probably know, for most of the questions and recommendations we're looking at for post-COVID condition, there just hasn't been any research done yet. So, or published, I should say, because there's lots happening now. And so a lot of the recommendations, we had to use indirect evidence, so different populations. So another recommendation made by the CAN-PCC was looking at treatment with melatonin in addition to sleep hygiene. So in individuals with post-COVID-19 condition and sleep disturbances, the CAN-PCC collaborative suggests using melatonin in addition to sleep hygiene advice. This was a conditional recommendation, again, based on very low certainty in the evidence. It's important as well for people to be aware that commercially available melatonin supplements may not contain the amount of melatonin indicated on their labels and may also contain additional substances such as serotonin. So in Canada, it's just not, the commercially available products aren't as well regulated.
Okay, so for anyone who knows anything about me, sleep is my jam, I guess. It's my area. And so I just wanted to quickly run through just a quick run over of sleep hygiene. And really because there are a few pieces of this that I think are sometimes not understood as they should be. So most of these things are intuitive, like try not to drink alcohol in the evening. It might put you to sleep, but it will fragment your sleep. Try not to have a lot of light or sound in your sleep space. Very intuitive. The ones that I think can be a little bit less intuitive have to do with the regularity of sleep. So all too often we think of sleep hygiene as being, go to bed at the same time every night. And actually, if you're struggling with sleep, we would say that is not nearly as important as waking up at the same time every night. And to remember that a pattern of going to bed earlier and earlier to compensate for poor sleep actually perpetuates insomnia. So just keeping that in mind as a recommendation. It's a little bit of my pet peeve when I hear that as a recommendation, go to bed at the same time every night. It just doesn't work if you're not falling asleep at the same time every night. Yet if you have good sleep habits and pattern and sleep is not a problem, then yes, going to bed at the same time every night can be really helpful. So that's just kind of one that I wanted to point out. Otherwise, as I've said, most of these are very, very intuitive, but I'm not going to read them all to you, but the slides have the instructions and the rationale for each. And if there's any questions at the end about any of those recommendations, I'm also happy to answer those. Next slide. And I'll just comment a little bit on melatonin dosing. And so, yes, the point made about Canada not having great regulation to melatonin, I think, is a really important one. One of the things that you will see when you go to purchase melatonin is these very high doses. Often you'll see 5 milligrams, 7 milligrams, 10 milligrams, and intuitively people may use one or even two of those. And really, when melatonin is used appropriately, you don't need such high doses. A lot of the evidence actually comes from studies where they looked at really, really small doses. At higher doses, people might get sleepy, and that's because of an antihistamine-like response. And so it's sedation, but it's not the core action of melatonin that we really want, or that we're looking for when we use melatonin for sleep. So what we want to do is look for those lower doses I say 3 to 5, but as you can see in the study, I've put here doses as low as like 0.1 were evidence to help. And you would take them 3 or 4 hours before intended sleep time, because we're trying to mimic the natural kind of melatonin secretion in the brain. And so, of course, if you take it at 6 p.m., at the low dose, we would not expect you to get sleepy at 6:30, whereas with high doses, one might. And then so one might take it late at night to get the sedation. But then what we're really trying to do by giving your brain this sort of messenger, this hormone, supplementing it to say it's nighttime is for sleep, is we're taking it too late. So if we want it to work kind of physiologically, like to mimic what's normally going on in the body, you actually want to take it a few hours before bed, and not take it to get sleepy in that moment, but take it to help prime your brain to be ready for sleep when it is sleep time. So yeah, I think that's all I'll say about that right now. So next slide.
Thanks. So I just thought I'd share a little bit about my own lived experience. I know some of us, I run into people all the time who've never met someone who has PCC, and so it's a little bit, it can be interesting and potentially informative. I've had an interesting experience with it. I developed PCC after a first infection that I didn't at the time know was COVID because it was very early in the pandemic, but I traveled for medical down to Vancouver with my son. I live in Whitehorse, right up in the north. Came back, we developed quite a nasty illness, fevers, cough that lasted a long time. And so what happened was that I started to develop these just in like I couldn't get better. I felt like I constantly had like a cold and chronic sinus issues. I started having trouble with breathlessness and ended up eventually going on puffers. And then I started really developing what we would call brain fog and fatigue. And those really increased sort of slowly, but got quite severe over, I would say, the next year. And so I lived with those for about 2 years. And then when I got my second infection, it was in April 2022. Again, I think I've only ever caught COVID during travel. Interestingly, after 4 weeks of being quite ill, so many of my long COVID symptoms improved. And so I thought that was, obviously it was a bonus for me. Interesting to try to think about what was going on there. I got a third infection, unfortunately, in December of 2022, again after travel. That infection was just very focused in my sinuses, and I honestly have had like almost chronic sinus infections since. So lots more, like it's just every time I've been infected, different symptoms sort of have stuck. And then I got a booster, would have been my fourth vaccine in December of 2023, and I had a really big crash actually after the vaccine. I hadn't had one in a while. And so I probably spent about 6 weeks having really significant fatigue, brain fog, muscle pain, all of those things. And then unfortunately, a fourth infection. I know there's some talk about, a lot of the people who get PCC potentially are also just really prone to getting COVID. Because I promise I try so hard to avoid it, but I do travel a lot for work. And since the fourth infection, I have developed POTS. And so just a really interesting, trajectory. And so if we go to the next slide, just to speak specifically to sort of the mental health pieces. So I do have a comorbid anxiety disorder. It's been a long-standing one. I would call myself a functionally anxious person. I have been on medication for quite a number of years because I think it was around the time when I had my pregnancies and some hormone issues, I developed panic attacks. And so the medication really just sort of stabilized that. I did find, of course, that my anxiety has been increased since I've had a post-COVID condition. And I mean, in my brain, that just makes so much sense. I constantly have all these weird feelings and discomfort. And new symptoms that just show up, and there's just so much. And then all the, like you were saying, Rachana, when you add all the pressures that it has added to my life, to being able to socialize, to being able to parent my children, to being able to work and make money, right? That just really increased my anxiety. I did also experience an increase in depressive symptoms. I haven't taken medication for those specifically, partly because I just get all the side effects from the medication, but have been able to manage them through more lifestyle sort of changes. And then another thing I did want to mention in relation to the fear, I guess, and the concern that people with lived experience might have around, not being believed, or people thinking, well, it's all in your head, or, well, you're just anxious, or you're depressed, you're fine. That I did have suggestions of that initially, especially before we sort of figured out that I likely had COVID, and that I was actually experiencing post-COVID condition. And so, that's not something that was, even I experienced that as an occupational therapist, someone who works in the field and understands a lot about this, even to the point where I actually saw a specialist quite recently. And even though I'm already diagnosed with post-COVID condition, and I'm an OT, and I'm part of this guideline development, this person still suggested that perhaps a lot of my symptoms were because of heartbreak from a divorce that I'd had about 5 years ago. So just, you just never know. And I've come to understand that even though I can advocate for myself fairly well, I think I still go into almost every appointment weary of what the response will be. I do want to mention, on a positive, I just saw recently, for a specific issue, a resident at the family practice where I see physicians, and he's young. He was amazing. When I mentioned I had post-COVID condition, he just instantly seemed to take it, seriously, wanted to know how I was doing, how he could help and support. And so that was just, it actually caught me off guard, but it was just really, really refreshing to have that experience. Yeah. So I think that's it for our presentation. There are some references. Yeah, and then we'll, I guess, move into the Q&A.
Welcome to place your questions in the Q&A, which is anonymous, or in the chat. Welcome to also put up your hand, and we can unmute and ask questions there as well. So we do have one question, and this was a question regarding the mental health conditions and management in PCC, that 2022 Stats Canada data. And it said that data from 5 million surveyed in 18% of age 15 and up met the diagnostic criteria. So we're just curious if you happen to know at this moment, and if not, we can respond later by email. Just the methodology of that survey.
I would have to go back and check. It's all publicly available. It's published on StatsCan, but I could not tell you off the top of my head what the methodology was. I think it's a good question though, because how do you do it? And I suspect it's survey data, right? So it's not going to be that structured clinical interview. That would be much more specific. There's always a question of oversensitivity in surveys related to mental health, but mental health is so subjective that whether or not we objectively score a certain way based on a structured clinical interview, I think that if an individual is reporting they're struggling with the mental health symptoms, we will take that at face value to say this is clearly not the baseline for a person, that they are struggling with the symptoms. But I think that's a good question for sure.
Great. So thank you, Rachana, and we'll follow up with an answer. We can even put the link to that report so people can dig a bit deeper when we send things out to everybody. So there's no other question. Oh, so I've got some questions coming in now. So one of the comments or questions would be, what about speaking slowly, potentially not being a good screening question, because many PCCs may not, many with PCC cannot talk as fast as they used to. And I also see a second question from Elaine that I will return to.
Yeah. So, I mean, I think again, if we think that the speaking slowly is secondary to the COVID infection and it's part of the post-COVID condition, then we would take it as a neuropsychiatric manifestation of the post-COVID condition. So it would guide us in terms of like understanding what all the symptomatology is. But does it necessarily feed like is it representing depression? Not necessarily. And I think that's why it's so important not to rely just on these screening tools. Um, Outside of the fact that screening tools never give us the nuances, none of these were created for the post-COVID condition. We don't have that yet. And so when I look at those types of screening tools. And if I see that someone has marked off that they are speaking slowly or moving slowly, then I'm going to just ask about that symptom in general. I just use it as a stepping off point to have a discussion about symptoms that a person might not actually come in to endorse. It's very unlikely, I think, or at least probably quite rare that someone would come in with that particular chief complaint as I'm speaking more slowly. There's probably more going on. But as much data as we can collect about all these other potential outcomes, I think will help us guide and focus our treatment a little bit better.
Yeah, I'll just add a little bit too. I know for me with the brain fog symptoms, like brain fog is really, and actually we're doing a presentation, I think this Friday on that, is really about executive functioning, right? So for me, been a big part of my symptomology that's super challenging as someone who's used to feeling like they can speak intelligently, right? And do these kinds of things. And so I know word finding has been one of my biggest challenges. You probably heard it during the presentation. And so slowing down sometimes helps me to find my words. There's also, I think, a bit of like even just attention and focus that can affect the speed at which you might be able to speak. There's so many just different factors that could be playing into that. Yeah. So I agree.
I want to add that we didn't really talk a lot about brain fog, but that's not to minimize the prevalence and the importance of it. Brain fog is a huge presenting complaint. The problem is we don't really have a good, I think, treatment strategy for it, nor do we have good measurement tools for brain fog. And so that is a huge problem for us. I don't want to minimize that brain fog can be a huge part, if not sometimes the only presenting symptom that from a neuropsychiatric lens in this condition.
And I really do encourage, if you have not yet registered for the upcoming session on brain fog, there'll be a link in the chat for registering for further webinars, and please do come and listen to that one as well. I also wanted to note in the chat there was a thank you for being so self-revealing, Melissa, and thank you for bringing that lived experience into this session. There's a bit of a question I think relates to what we were just talking about, and it was about the idea that if people are overwhelmed or have really challenging symptoms from COVID, like you mentioned, brain fog, fatigue, everything else, when you're presented with somebody who has that challenges of those COVID symptoms, plus also has anxiety and depression, it's almost like, how do you manage like all of those kind of pieces and all those parts together, and what does that look like clinically?
Yeah, I can jump in just quickly to say that for me, even in my lived experience, but also in my clinical experience, I mean, that's part of the symptomology almost of depression, especially is that, and it's not lack of motivation, it's honestly a lack of energy or ability to do some of these things. When you add in the fact that during, over the course of the pandemic, yeah, things are more available now, but there was a real lack of availability to go and find a clinician and to get support. That's a challenge just in terms of primary care and family physicians all over the country. But also even the financial ability. I was self-employed, unfortunately, when I first was diagnosed. I had no benefits, and I was struggling just to put food on the table for my children. So for me, the idea of being able to pay for counseling and even sometimes for medication was super challenging. So I think this is where, for me, I want to advocate is that it's one thing to help, diagnose some of these challenges, but when we have these people who are really struggling, and then we're trying to give them all this advice about, which is good and important, about like lifestyle, remediation. Oh, you need to sleep and you need to drink water and you need to eat well. I mean, there were so many days where I had to DoorDash McDonald's for my kids because I couldn't get out of bed to make a meal. So, and then I didn't have the money. Then I ran out of money. But anyways, that's so it's just really thinking about how we're supporting someone to access all of the supports that we're suggesting as well.
Yeah, and maybe one thing I'll add is this is personal now. I've always had a problem with this idea of categorically telling someone that they have depression, or that they have, like, we know that people don't exist in categories. We are dimensional, right? And so the experience that we might conceptualize as depression is made up of a number of physical, emotional, like so many different pieces, um, and can be expressed and lived in different ways. And so my clinical approach to this is, we could diagnose depression based on criteria. We could diagnose depression secondary to a medical condition as well and call it secondary to COVID if we wanted to. That our diagnostic manual allows for that. But my personal approach is to try to target each symptom. And so when you look at each symptom individually, then you can look at all the different factors that can be contributing to that presentation. So low energy, fatigue, is that related to poor sleep? Is that related to stress? Is it related to the development of an anxiety disorder? Is it related to the condition of COVID itself that's draining someone of energy? And then try to address each of those individual factors rather than trying to figure out, well, is this depression and depression alone, and let's just treat the depression, versus just trying to address each of those individual symptoms. Because absolutely there's overlap. It's every one of these symptoms can be multifactorial, and one factor can then perpetuate or precipitate another factor, right? And so it is very difficult if we're trying to come at this with an approach of like first diagnose, then target treatment. The diagnosis itself would be, I think, the post-COVID condition. And then from there, looking at those individual symptoms and trying to target it. One other thing I'll add that we didn't talk much about is stigma, right? And we kind of touched on it. Melissa talked about feeling like you're being, gaslit or not believed. And even if you are believed, there is stigma, I think now. We know that there's stigma generally with mental health conditions. There's a worry that if you present with depression or anxiety, that you're going to be perceived a certain way, or that it reflects some kind of weakness or lack of resilience or something like that. And we know from our professional background that that's not the case, that these are clear medical conditions, right, that we should treat just like we would treat diabetes or high blood pressure. But the stigma is there, and I do see that spillover now of that stigma onto these types of symptoms when they are comorbid or as part of the post-COVID condition. I think that that's a huge piece to address, as a profession and as a community.
Thank you. Thank you both. There was a great comment in the chat just saying this is excellent. There are a lot of families torn apart due to judgmental attitudes, especially around vaccination and then sickness. Is a real eye-opener for the public and the families. And also those experiencing grief and not being aware that this is acceptance of this with the lifestyle change with this as well. Any kind of comments on like maybe how families can kind of support somebody who's going through this complicated piece? And then we have a question just about mental health screens for PC patients, if any specific ones are being developed. And I can repeat the second question later. So the first question was just any comments on like how families can support when someone's going through this complexity, or any other comments about facing that stigma?
I think I can jump in. The comment about grief actually really hits home. And so there is so much grief and loss. And that is really a process. I've actually done a deep dive into that lately for my clinical practice, but it's helped me understand so much of what I've been going through. And so that's a huge piece to having a chronic condition or having a new condition and having to accept changes in your lifestyle. For some, they're more minor, but for some, they're really major. And so I think, looking to get real supports for your family members and your friends who are experiencing this, that actually, the supports that relate specifically to grief and loss, I think would be really important. Another thing, and this is, I'll just put in my OT plug, is that participation in activities that you enjoy is one of the key ways to continue to have quality of life. So finding those supports that help you in whatever capacity with pacing and prioritizing, and how can you just have people gather around and support so that you can still do the things that bring you joy. That is so important for everyone.
I actually wish I could give a better answer in any way, and I can't. Like I think that my approach with families is to approach it like I would anything that my patients are suffering from. I think it's valuable to involve family. I know that I'm hopeful that we'll have more groups. Like we know we have family groups for other areas of health and mental illness. And I'm hopeful that there will be more of that. What we need is a lot more education. And so I'm very personally open to my patients bringing in any kind of family that they might have. But it's very difficult otherwise to give a specific kind of recommendation of how to support someone at home. I think it's just sort of helping to battle that stigma. I think is kind of one of the best ways that a loved one can stand with someone who's suffering with this. Yeah. Yeah, I think that's all I have to say about that. I can tackle that second question. I don't know that we actually, again, I don't know that there's there's the development of specific questionnaires related specifically to neuropsychiatric symptoms in the post-COVID condition being developed. There are other questions. There are ones that look at functional status that are being developed specifically for the post-COVID condition, and even some quality of life indicators specific for the post-COVID condition, but I don't know of any others. I don't know if you guys do.
Yeah, I'm not aware of any as well, but we do have research recommendations that go along with all of our CAN-PCC recommendations. So, and we can definitely continue to advocate for these pieces for sure. Yeah.
I'm going to go through kind of our housekeeping slides and then pick up some extra questions if there are. We wanted to just highlight there are resources available for patients. So my guide, which is going to be including the CAN-PCC recommendations, is in progress to further integration because the guidelines and our recommendations are still coming out. The integrative infographics and online resource sheets, and then these webinars as well as the ones by CAN-PCC. Similar for resources for health professionals, we have accredited webinars, an online CPD course that's going to be coming out, and then additional resources, EBM Connect Canada. So I want to say thank you so much for attending. We want to say thank you tremendously to our speakers. And then just a reminder to stay up to date, both with the guidelines and the recommendation map, which you can see as a link here. And these links will be placed in the chat as well as with the upcoming webinar series. And then the evaluation form is coming out as well. Yeah. And then one of the questions that came up also in the chat, it was just a comment that was very really important to help speak about mental health and that importance there. And then I don't see any other comments or I don't see any other specific questions, but just additional comments about how important this conversation is. So thank you both tremendously for today and for your time and for sharing your experiences, both personal and also clinically with our people here today. So thank you both.
Thank you.